Welcome to the Health Economics and Policy Unit at Carnegie University of Health Sciences. 2025 has been a year of tremendous progress, from right here in our Blantyre offices to our team in Lilongwe. We have worked to bridge the gap between policy and research. In this end-of-year report, we dare beyond the data. We sit with survey researchers and policymakers and support staff who drive the mission of HEPU. In this video, we're going to hear about the Thanzi program, international conferences, and the progress that we have made. To kick-start it off, we're going to turn to our Director of the Health Economics and Policy Unit, Professor Joseph Futsebengo, to take you through the major milestones of 2025 and what 2026 looks like for us.
The year 2025 was a very successful year for us at HEPU, and we had three very important think tanks. The first one was looking at HIV sustainability options in Malawi after the withdrawal of donor funding from USA, and there was a lot of discussion on that, and I think the conclusion was aligned to say that we need to find the ways of sustaining ourselves. And one way of sustaining ourselves was integration. So you can see that there was a development from a shock which came from a withdrawal of aid. People started discussing about sustainability option in the first think tank. The second one, emerging thinking about what are the strategy, financing strategy. The third one, the final one in the 2025 was sustainability planning in health sector using Thanzi model, which is all disease, all system model to guide integration and efficiency. We witnessed that three of our activities, project activities, were institutionalized by Ministry of Health, by Malawian government. First, namely, direct facility funding became a policy, and it was integrated as part of the Malawi government policy, including also HTA. We saw the initiation of institutionalization of HTA, health technology assessment. Very interestingly, we saw the scaling up of Thanzi model, not beyond the borders of Malawi, being adopted by other countries, including Tanzania, Uganda, and Kenya. At the end of the year, we were given an award by University of York. The award is called Weaver Award for the impacts. We also contributed to the convening of ASPA Conference, Africa Association of Public Health Conference, and Africa School of Public Health Association Conference, and also Public Health Institute of Malawi.
Yeah, so my name is Lucky Giftingwira. I work as a senior health economist within the Health Economics and Policy Unit, responsible to leading the economic evaluation, but also I'm responsible for research coordination. When we look at the work streams within HEPU, there are two aspects to it. So number one is, as you know, we are within academia, we are within the university. So there's one aspect which is teaching. And then the second aspect is looking at the research. So the research is kind of in two bits. So number one is MOH driven. So MOH commissions us in terms of work that we should look at. In summary, we're looking at the health technology assessment, which is institutionalizing the whole process of evaluating a health intervention and its adoption in Malawi. And the second aspect is the DFF, so that's direct facility financing. And this is really looking at devolving the funding so that it goes at the point of care, and they can determine what to utilizing and whatnot. And then we talk about the service level agreement. So that's the arrangement within the Ministry of Health, rather government and the non-profit organizations like CHARM and IHAM in terms of service delivery. So we've been assisting in informing the government the value for money for CHARM. Other than that, there's also human resource for health, market price analysis, and all these are different aspects that are commissioned by the Ministry of Health. So that's kind of first layer on research. And the second layer under research is those that are driven by grants. So we've got the Thanzi, for example, whole system, whole disease model. So really, first of its kind, that is looking at modeling all diseases, the interaction between all diseases and how this interacts with the health system. And we're happy to say this has worked in Malawi and it's being replicated in other parts of the region. And then the second that I mentioned is the NEO-tree, which is kind of a semi-automated AI to help in tracing the neonates to have better outcomes. This is funded by FCDO with support from Gates Foundation.
So it's been a busy year. We've been working on generalizing the model. That's mostly done by our friends in Excel. So in terms of that, basically we're just trying to make the model more accessible so that even though we're able to use it here in Malawi, it should also be able to be used in other countries like Tanzania and other African countries. Besides the model, I think there's also some other work that's going on climate change. So basically just trying to add in some climate change path goals on so that we should be able to see maybe natural disasters occurring and other things. We have a number of pieces of work that are going on. We have kidney transplant. Then we also have diabetic retinopathy, which is ongoing, and that one too we also should be able to start analysis. So we have direct facility financing and the CHARM work, but these are mostly conceptualizations. So yeah, we're still getting them done on paper before we actually make them into code. So that, in a nutshell, that is what we've been able to do on the model.
I'm Sebastian Boma. I'm a research fellow, health systems and policy. Last year, I should say, we were engaged in HDA institutionalization. So we developed a framework for HDA institutionalization in Malawi, and it was adopted by the Ministry of Health. So as a way of piloting the HDA institutionalization, we were tasked to do a rapid HDA on this, and this was to be done in 3 months. Looked at 6 isolated dimensions of all safety, clinical safety that is, clinical effectiveness, cost effectiveness, the else, which stands for the ethics, legal and social issues in relation to these technologies. We also looked at the legal framework that will support the adoption and the institutionalization as well as implementation of these technologies. And then we also looked at how the purchasing and supply chain management would accommodate these technologies. With the coming of health technology assessment, we would like to strengthen decision making by bringing in evidence that is robust, that is balanced, coming from different sectors, zooming in at each and every decision that the ministry would like to make, as well as the technologies it would want to purchase and the policies that it would want to implement, including, say, immunization and any other policy that the ministry would want. So this generation of evidence that is done in HTA is very important, because from now onwards, the decisions that are going to be made by the ministry in terms of the technology that need to be adopted are going to be informed very well from a robust and scientific based evidence.
My name is Joe Makangazoda. I'm a research fellow in health economics here at Health Economics and Policy Unit at KUHES. So this year, 2025, our team conducted an evaluation examining how different provider governance structures shape financial management, financial autonomy, accountability, as well as service delivery across these faith-based institutions, particularly in CHARM and IHAM facilities. This assignment has been particularly timely, considering the fact that the Ministry of Health is advancing several health sector decentralization reforms, including the direct health facility financing reform. This was done across a total of 41 facilities across 16 districts in the country. What we found was, one, for facilities with a functional board, they demonstrated stronger public financial management as well as autonomy, unlike facilities without a functional board. Those with dedicated boards, they have stronger or superior performance in terms of public financial management as well as financial autonomy relative to their counterparts with centralized boards. In terms of policy implication, we advocated or we advised the Ministry of Health to pilot the facility boards within the public sector or the public facilities, leveraging the current implementation of the direct facility financing, so that within this reform there would be enhanced accountability as well as enhanced PFM environment.
My name is Precious Chitsuro, and I am a data scientist within the Health Economics and Policy Unit, HEPU, at the Kamuzu University of Health Sciences, KUHES. This TLM study, TLM stands for Thanzi, was actually conducted last year, and by the end of last year, we had successfully completed all data collection activities, and we also had submitted an initial paper that described all the 6 datasets from the study. And this year, my work has largely focused on supporting various teams that are working on manuscripts. The first manuscript is a paper that is called Patient-Reported Travel Time, Direct and Indirect Costs of Attending Health Facilities in Malawi. The second paper, it's a paper on health worker time use in Malawi, a time and motion study. There is also another paper, it's titled Ownership and Quality of Primary Care, a comparative analysis of public and faith-based providers in Malawi. The last one is a paper or a manuscript that is being led by Dr. Joe Collins from UCL, University College London, and it's focusing on healthcare service user-reported quality of care in Malawi, a national multi-facility cross-section study. We are in a process of finalizing the anonymization and doing further cleaning to the data in order for us to be able to make it available. We have created a repository on Zenodo. It is a repository that is owned by HEPU, and we want to upload all the finalized datasets on there for public use. And once documentation is completed, we will make the data public, and then we will submit the papers that are finalized to the publishers for consideration.
I'm Peronora Pamba, a Health Economics Research Fellow here at the Health Economics and Policy Unit. And as one of my projects this year, I've been working on this project, the political economy of urban mobility in Africa, together with colleagues from the Makerere University School of Public Health and the University of Rwanda. As cities in most African countries are rapidly expanding, they faced a lot of challenges in traffic congestion, unsafe roads, informal transport growth, but also limited accessibility, which actually threatened some of the global goals, Sustainable Development Goals. For example, SDG 11 on sustainable cities, but also SDG 3.6, which focuses on reducing road traffic injuries. Mobility in these African cities, Lilongwe, Kampala, and Kigali, in most contexts, is not only a technical infrastructure issue, it is actually deeply rooted in politics, power relations, institutional fragmentations, and interest of various actors in the field. In understanding who holds influence, whose priorities dominate, but also how decisions are made, is essential in developing equitable mobility reforms. And that's where our project came in. It is very vital because it maps existing policies,
various actors. It engages decision makers, and it aims to strengthen local capacity to support more inclusive and sustainable development. As part of this work, we've conducted in-depth policy analysis of mobility policies and transport frameworks across Kampala, Kigali, and Lilongwe. We also developed a conceptual framework that links the political economy of mobility policies to their health implications.
COHES is a member of the P4H academic group. So the P4H is a network of organizations hosted at WHO Geneva. These are joined by a common goal to support countries design and implement health financing systems that have social protection at their core. HEPU presents COHES, and COHES is a representative of the universities in Africa on the P4H academic group. I must also say that as part of the initial interaction when we traveled, we've been working on an MOU with Fudan University to strengthen cooperation in global health and student exchange. And so this was also part of it was a forum to kind of follow up on the MOU, which is currently concluded, and this will strengthen the collaboration between Malawi and China. The participation in the P4H network is important because, as you know, Malawi's health financing is one of the lowest in the globally, and there have persisted calls to reform, and so this helps us to be on top of the conversations on the designs of optimal designs for health financing, so that we, at the core of the conversations, the reforms, we embed social protection as a key goal. We've been collaborating with Makerere University as part of the TRANS program, but inside it, there's a new small partnership that's emerging on political economy of urban mobility in Africa. There are also other members who are beginning to get interested in the space. So so this is a small grant, but it's having significant impact on or in shaping how we integrate political economy from our regular economics work that we do. One of the work streams under HEPU was accepted for presentation at the International Health Economics Association. This happened in Indonesia. I think these international trips are really important. In academia, exposure is everything. Networking keeps us going, exposes us to innovations, developments in other countries.
As HEPU, we believe in capacity building, and we are making initiatives to make sure that our teams are trained and equipped with the right skills to undertake all the economic evaluations that they need to do and all the modeling that they need to do. Started with the DHIS2 training, which was aimed at equipping the teams to be able to use existing data for the different analysis to inform policy making. We also had an Excel training, which was also aimed at equipping the teams at the team at HEPU and also members from the Ministry of Health on how best to use Excel for planning and also for different analysis that we undertake here at HEPU. And we also had an online training on modeling and scientific writing. This was also very important because as researchers, we have to publish our work, or otherwise nobody will ever know about our work. Nobody will ever know about what HEPU does. The DHIS2 training was really beneficial because most of the members are now able to use the existing data, the DHIS2 data, to do the different analysis that they are doing.
2025 has been a journey of growth for me, honestly. When I look back where I'm coming from, I've learned quite a lot from HEPU. I remember starting this year, joining a new project. That's the NEO3 project, where we're looking at the newborn digital health innovations being implemented in Kasungu District Hospital, as well as other 10 primary health facilities there, with an aim to improve the quality of care among the newborns. So this is an intervention where I'm coming in as a health economist to do the economic evaluation aspect of the work. Getting a PhD scholarship from Bill and Melinda Gates Foundation was just incredible. That actually added a layer of growth, to myself. To be honest, it was not an easy thing, but I got that scholarship from them. I'm so grateful to HEPU, but also to Bill and Melinda Gates. So this is a PhD that I've just started with CUHES in collaboration with University College London, where I'm actually looking at the economic evaluation aspect of that newborn digital health intervention here in Malawi. It's not just about the research that we do, but also trying to inform the policy out there so that we can actually strengthen our health system.
I joined the Health Economics and Policy Unit in January 2025, and this past year has been one of tremendous personal and professional development. My most memorable thing about HEPU is the culture for strong collaboration with both the Ministry of Health as well as international partners. I have also noted the team's strong commitment to inform policy using evidence. I have had the opportunity to work across multiple work streams within HEPU, firstly starting with the CHAM and DFF project. I have also been part of the Health Technology Assessment project and also had the opportunity to be part of the first HTA process to happen within Malawi. That is something I am deeply grateful for. In addition to this, I have had the opportunity to present at the 4th Research Dissemination Conference hosted at CUHES. I am grateful for the opportunity to bridge clinical practice and evidence that informs national decision making.
We are looking forward in 2026 to start Masters in Health Economics and also more research proposals, writing more publications, more policy engagement, and also another great expectation is that we are looking forward to scaling up a think tank by Ministry of Health to become HSSP3 think tank. Without a vision, you cannot achieve a lot. So this is our vision. We hope that the God blessing it will be done.